Hey everyone, welcome back. It's season 2 of Overfilled, the podcast. We are so glad to be back. And as you can see, Dr. Jamie Kuzniar is not with us. She's actually left the podcast. So we've upgraded the show and we're happy to introduce our new podcast host in a few minutes. Let's go ahead and just remind everybody about what Overfilled the podcast is all about and kind of our mission for sharing these episodes with everybody. So Jason, can you tell us where the inspiration for Overfilled the podcast came from?
Sure. So again, hopefully you missed us. It's been a couple of months, but we are back, better than ever. And Overfilled the podcast. What the goal here is to this show is for anybody who fits specialty contact lenses. And it's an opportunity for us to share about the highs and lows of practice, hopefully more highs than lows. And if you're sitting out there going, well, I'm not part of the podcast, how can I share my highs and lows? You absolutely can, because we beg you all the time to please send us your cases, your stories to overfilled_the podcast on Instagram, or to Overfilled the podcast on Facebook, or email them to us, overfilledthepodcast@gmail. Send us videos of you talking about what overfilled you. Okay. And I've got, it's been a couple months, so I've been stocking up on the good stuff. So over the next several weeks, we'll unpack a bunch of videos of patients loving their lenses and cool things that we've seen and done in practice. So again, this is not just for us, this is for everybody. Mm-hmm. And so send us what overfills you. In the meantime, we'll tell you what overfills us.
Yes.
And then we also want to talk about something relevant to scleral lens fitters. And so that could be cases. It could be, just like I think we're going to do an upcoming episode on lens modification. But we have a different theme today, which we'll talk about in just a second. So that's what Overfilled is about. It's about sharing what scleral lens fitters.
Yep.
And so send us your cases, make a video of yourself talking about what overfills you. We will play it right here on our podcast for all to see and hear.
Thanks for the quick intro and reminder to everyone or people who are new. The reason we haven't been around a bit is because we've had so much going on with the fall meeting season and things like that. We like to record our podcasts on Wednesdays. And to be honest, that's a lot of the times the travel day to go to these fall meetings. So we've just had a really hard time lining up our Wednesdays to connect. And then we're traveling on Fridays, which is another day we try to record podcasts. And so we just needed some time away to go and get charged with all the new stuff coming around with the fall meetings. And now we're back a little bit more consistent schedule. So we're looking forward to connecting with you frequently now. What overfilled me since we've been together probably a couple months, mostly just fall meetings, connecting with friends and colleagues across the country. Here's our former co-host, Jamie and I at the Contact Lens Society of America. And then Jamie, myself, and Carrie Rivera from Bausch & Lomb at the same meeting there. And so it's always good to see these two. And then on the next slide.
Well, hang on just a second, Brooke.
Okay.
That should be a plug for the CLSA meeting.
There we go. It was awesome. Jason and I are both involved. Or, well, Jason, you're more involved than me. I was just a speaker this year.
Well,
and you're on board.
But for anybody who doesn't know what CLSA is about, it's the Contact Lens Society of America. It's been around for like 75 years, and its mission is just contact lens education. So there's a monthly publication that comes out. There's an annual conference, or not monthly publication, quarterly publication that comes out. There's a yearly conference. And there's online education stuff. And so if you are a contact lens specialist or want to be one and working your way that way, and you want to be involved with an organization, look up clsa.info, I think it is, and get involved, because it's an opportunity for you to get into speaking, writing, whatever, in a way that is easier maybe than it would be to get in with some larger organizations.
And the one thing about the CLSA meeting that completely overfilled me was I was able to bring my lead contact lens tech and my scribe with me, and they sat in on the education too, because there's some more advanced topics and some more entry-level topics, and they bounced it back and forth between the two lecture halls, depending on what was most applicable to what they wanted to learn. And they were so excited about what they learned. You know, we all came back with really good ideas, and I feel like it was just an amazing way for the three of us to really bond. And now they understand a lot more of what I talk about when I'm educating patients, or even just mentioning what I'm modifying on fits. And so the CLSA meeting was just exceptional. It was in San Antonio, and we had just a great time.
Yeah, and a pretty affordable meeting too overall.
Yes.
So again,
yep.
Yeah.
And it's so small that you feel really comfortable asking questions, because it's not a 700 person lecture hall. You know, you're with another maybe max 100 people, and a very intimate meeting to connect with people.
Yeah.
Jason, this is an overfilling moment for you.
Yeah. So another meeting that happened recently was the American Academy of Optometry conference, and it's obviously it's not just for contact lenses, but it's all specialties. But we have great contact lens education there as well. Shout out to AAO. If you're not a fellow, consider it. And if you are a fellow and you do contact lenses, consider the diplomate section, as Brooke tests. She's going through the process right now, I believe. Yeah.
Yep.
So
still going through it.
Yeah. Well, so this was a great opportunity. On Friday night of Academy, Indiana University had a reception, and I happened to be there, as well as in this picture, 5 of our current and previous contact lens residents. There was actually 2 other contact lens residents who were at Academy that weren't in this picture, but I got to see. So I've been at Indiana University now 10 years, so 10 residents, and 7 of them were at Academy. Really cool opportunity. And just again, to have 5 of them, and actually Jamie was at this reception and left right before I got there. Otherwise there would have been 6 of them together. So it's a great opportunity. These were actually our last 5 contact lens residents at IU, and they're all doing great in practice now and making us all proud. So this is a super cool moment. I just looking around the room like, there's so many previous residents here. We need to get a picture. And yeah, it was pretty neat.
What's next? Well, we got another overfill. Oh yeah, this is a good one. Jason and I got to lecture together at Academy, along with 2 other colleagues, Dr. John Gellies and Dr. Clark Chang, and we talked about controversies in keratoconus management, and it ended up being a pretty fun lecture. And so we just snapped this one sort of mid-lecture.
Which is a nice lead in to our topic today, which we'll bring up in a second again. So we're just dropping Easter eggs all over the place here.
Super overfilling moment here. We actually, since Academy ended on Saturday, we elected to stick around Indianapolis for another day. And the Colts were in town playing the Bills. And Charlie Creighton there, he's the one to Jason's left. He's another
one in the Bills gear.
Yeah, the one in the Bills gear. Yep, he's an integral part of all the contact lens, moving the contact lens field forward. He was a big partner with you, Jason, in Zen Lens design, and the 2 of you always have something sort of gears turning in the background, thinking about improving the contact lens industry as a whole. And we were joined by Zac Holland. Zac Holland is, I don't know, how does he fit in our family tree, Jason? He's like,
oh my gosh,
like a cousin, or what is he?
Well, I mean, if you want to get into that kind of it, he's more like a child than anything, but he's a grown-up child now. He's grown up and is on the path to succeed or exceed his parents. So so Zac, and I'll bring Zac on as the new part of our team. Bye Jamie. Actually, we're just kidding. Jamie is not leaving the podcast. She was just busy today.
Yeah. So
for those of you who are like really cringing right now because you think Jamie's gone, she'll be back.
Yeah. We just couldn't wait to get back together now that we're on normal scheduling, and really wanted to get something back out to everybody. And Jason wanted to talk about keratoconus today. We wanted to talk about awareness around crosslinking, and Zac has a really neat practice set up around managing keratoconus. So that's why we thought he'd be a great add-on today to discuss with Jason and I.
So when Brooke and I practiced together, Zac was a 4th-year student in our practice. Yeah. Mm-hmm. And so one of the good ones, not that they mostly weren't good ones, but definitely one of the good ones.
Yeah.
And then as I left, then Brooke, you brought Zac in to join the practice, and now he owns the really cool clinic right behind him there.
Yeah.
Corneal Contact Lens Institute in Minnesota, which we're all still super proud of. And he's doing it right, surpassing our expectations. So it's good to have you with us, Zac. Thanks for being here on short notice.
Yeah, no, thank you. And I just do my best to continue the legacy that you both built. And I hope I get close to meeting your expectations.
Well, I
The
think
trajectory is definitely up. So
yeah. Can you tell us, before we get into kind of the history of the three of us together, do you have anything that has overfilled you recently?
Yeah, so like kind of you guys mentioned, we manage manage keratoconus on a regular basis. And a few years ago, we implemented corneal crosslinking into the practice, which is somewhat unique in an OD practice. And so I hire an MD. He comes to the office and performs epi-off corneal crosslinking. And because we were managing so many cases, Glaukos, the manufacturer for the instrument that does corneal crosslinking, came to me when they were doing some advanced clinical trials and brought a new clinical trial onto our plate. And so they're investigating the efficacy of epi-on corneal crosslinking currently. And so we're in that clinical trial. And today, actually this morning, we just exited our first subject from the trial.
Are you the primary investigator?
No.
Or does the MD have
the MD is the PI.
Okay. Is it who's doing your cross-linking now?
Adamos.
Yeah.
Yep.
Did you know, interesting, Dr. Moss is a cousin of one of our VTV surgeons, Vance Thompson.
I did not know that.
Yeah, I didn't know it either until, maybe a year and a half ago. But so there's little kind of branches of connection all over the place between all of our practices, not to mention the direct connection of Jason founding the clinic and then me taking over and then you taking over. So again, we have just this really neat familial thing going on here. But
how long did you follow that patient? Was that a 1-year follow-up or
18 months?
18 months. Okay, good. Yep. Nice.
Is that
how many patients do you have enrolled in the study now?
We have about 10. I think we have about 10 subjects or so, and everyone had a placebo procedure and the actual true procedure. So they were separated by a duration of time, but I think it was an 18-month trial.
Okay, cool.
In our epi-on corneal cross-linking trials, we've done 2 here. One of them included these little oxygen goggles. Is that the one you did, or did you do the other one?
Yes, it does include that, the goggles. Yeah.
Okay.
Neat.
Yeah.
Yeah. So again, we had cross-linking procedures in our office today too. So we have a cross-linking unit at the School of Optometry at IU also. So, people are like, oh, you guys do cross-linking at the optometry school, thinking again, it's a surgical procedure. And then I thought, well, Zac, you guys do it in your office. I know there's a couple other offices that are starting to do it too, that are OD-based offices. And whether that is in a state where it allows the OD to do the procedure or whether they're bringing in a surgeon to do it, either way, you're offering it in your practice. And of course, Brooke is at an ODMD practice where they do it.
Yep.
So all 3 of us get to work around cross-linking. And I just thought maybe it'd be a neat opportunity to talk about, is this something that more specialty lens fitters should be doing in their practice? Because we do see a ton of keratoconus patients, right?
Yeah.
And to be able to offer that to them, maybe you are in a situation where you already have it because you work with an ophthalmologist who does it. Maybe you're in a big city and there's someone a mile away that does it and you don't have the need, but maybe you're in an area where it makes a lot of sense for you to offer this to your patients. And so I thought, hey, we could talk about that. And then I'd love to talk about, again, some of the aspects of running cross-linking in your practice, Zac, like how you do billing and patient selection and how you talk to people about that. And what do you do when people don't have insurance and all that good stuff, if we can cover some of that.
Mm-hmm. Yeah, totally.
So you've had this in your practice, what you said, about 2 to 3 years?
Probably about that time frame. Yeah.
Okay. And what was the motivation for doing it? Why did you get started?
Because I'm in Minneapolis, for those of you that don't know, so there are some surgeons in the area that are doing both epi on and epi off crosslinking. A few years ago, to be frank, like I was referring out crosslinking, and then these patients would be lost to follow up on my side, or whether the surgeon never returned them to me. And so, or that I would send them to the surgeon for a specific procedure and then coming back with other things done. I was like, that's not what I talked to the patient about. That's not really what I wanted done with my patients. And so it kind of pushed me. Our Glaucos rep came into the office to say, like, hey, who are you referring for corneal crosslinking? And her and I had a discussion on like, well, why can't I be doing this? Like, this is a fairly simple procedure with really minimal potential side effects and complications. Mm-hmm. That set me down a path of researching what is allowed in Minnesota. How do we implement a protocol in our office? And it took like 6 months between the talking with an attorney, getting on board with the insurance panels, like hiring an MD, buying the instrument, and setting a protocol in place. But that's kind of what set me down the path. I just got frustrated with how the process was working. And like you guys know, this practice has a very like intimate relationship with your patients. Like, we spend a lot of time with each individual. And some of the practices that are near us that are super high volume, mostly by MDs, they just see a ton of patients. So I would refer patients there, and the patient would come back unhappy, not because they didn't get a good outcome, but because they were just run through like cattle.
Okay. So in the time you've been doing it, how has your experience been? Is it something you're like super glad you did? Was it been more of a hassle than you thought it would be? I mean, what's kind of been your feeling like? Is this something? And then of course I want to talk too about, before we're done, is this profitable? Are you doing this? Is the income it generates a nice bonus, or is it more a matter of, I don't really rely on this for revenue, it's more to give my patients the full comprehensive keratoconus management experience?
Yeah, kind of both. Yeah, I mean, we do generate revenue from it. It's less profitable now than it was a few years ago, primarily because when you bill these things to insurance, we're getting, there's a code for the medication and there's a code for the procedure. And the medication cost has increased significantly over the past couple of years, which eats into the potential profitability. I mean, insurance is only going to reimburse a certain amount for this. And so now the medication is essentially a break even for me. Mm-hmm. And we have to stock it in the fridge, and kind of, so we're prepaying for this stuff. And then we do the procedure, and then you bill the procedure, the patient knows the deductible, and then you're waiting a month or two to get paid by insurance. And so there can be a cash flow issue in your practice if you're fronting a significant amount of money and not actually making very much profit on the actual like medication. But there is a procedure code for the procedure, and that's something that is worth our time. The other thing, whether you're doing the procedure in office or you're referring out for it, there's a 0-day global period for the co-management. And so if you're referring out for the procedure, you should be billing for every single office visit that you're doing as a follow-up. I typically do a 1-day post-ops, 1-day, 3-day, and 7-day. Some offices skip the 3-day visit. Just being a new OD that's venturing down this path, I didn't want to take any shortcuts. I'd rather like over monitor people, mm-hmm. do a 1 month, 3 month, 6 month visit, more for monitoring the stability of the cornea. Typically, if they're in a specialty lens, I authorize them to rewear their lens at the 1 month mark. And then, so you're typically billing just an office visit for those first 3 visits, and then a topography, pachymetry, and refraction at the 1 month, 3 month, 6 months, plus an office visit. So that's all of those added up is probably about $1,000 per eye between all those visits and procedures. Again, we're only doing one eye at a time. And so multiply that times 2, depending on like, can you cross follow up on some eyes over the same visit. We try to do that just to minimize the number of times patients are coming in. But from that standpoint, there is some profit to be made, and it's relatively like simple visits. Like the first 3 visits are 60
Yeah,
seconds.
totally. Yeah.
Making sure that the bandaged contact lens is on the eye, making sure that there's no issue, and out they go. But to get back to the original question on like what other advantages, I mean, it's just a practice differentiating thing. I mean, I got a lot of patients who find me because we do corneal cross-linking. And then we inherit them as specialty lens wearers. And my existing patients like that we can do it in-house here. We bring in an MD, basically makes them feel like we're giving them the premium treatment.
Yeah.
Yeah, I agree. I think the idea of having this be just another part of managing their condition, where you're going to be doing the mapping to monitor for progression. You're gonna manage their disease. You're going to manage their vision, and you can do it all. And I think that's the key part of it, is to not have to have that patient shuffling between 2 or 3 different offices for the care they need. That you can do everything there, and you can do it at the highest possible level.
Mm-hmm. It's so nice for them to have just one point of contact of questions. So no matter what question they have about their KC, they have, one go-to person, which is, it's just simpler on all things. Like, you wish you had one doctor, one dentist, all those things, just one point person. And, but those patients, they, like you said, Zac, they do have that special relationship, and that practice in particular, you just really want to give them everything that they're looking for. And, you really try and meet both the emotional need that these patients have as well as the visual needs. And it's so nice that you're able to take care of them in that way.
Specialty lens, and you guys know this, and anyone that fits specialty lenses knows, like, patients that wear specialty lenses are extremely loyal, because typically they've been to 2 or 3 or 5 different eye doctors that couldn't correct their vision. And then they meet you and you do an awesome job and correct their vision. Like, I'll travel anywhere. Yes. Like, we have patients that move out of state and they fly back just to see you. I mean, we all have patients like that. And so just having that extra layer of trust with the patient, like, they trust you to make the right decision for whether it's a lens change or a surgical recommendation.
Yeah. What do you guys do after? So let's say you have a new patient, has never worn scleral hybrid specialty lens before. They come in, they're a young cone, you cross-link them, and then they are needing the vision rehab side of things, so they're ready for a contact lens. How long do you wait after cross-linking to do the contact lens fitting?
Probably about a month. I have had individuals who are like really chomping at the bit to get starting on the scleral lens fitting. And so I'll throw a lens on their eye at like maybe 2 weeks, and it's only on their eye for a couple minutes. I get a lens on order, and then I have it in place to dispense to them at the 1 month visit. I mean, because the scleral lens vaults over the surgical area, it's not so much wearing the lens that is problematic. It's a patient who doesn't know how to put in a lens in and out properly in like a brand new, like, re-epithelialized cornea. That's my worry. And so I really want to make sure that insertion removal goes like super well, because this epithelium is brand new, so we don't want them to damage that. And so that's kind of my indication, I suppose.
Yeah, I don't disagree with you. What about you, Jason? What do you do?
Yeah, so I have a thought about that. This has kind of been on my mind lately, to be honest. Maybe this was spurred by our keratoconus lecture at Academy, but we know from the data that the eye is going to keep changing for a year afterwards, let's say. We assume that there's probably some scleral shape change as well, because the cornea has been reshaped, or the corneal stiffness has been altered. So that's going to affect not just the corneal shape, but the sclera. It's all continuous. So if you wait till the eye is actually stabilized afterwards, you're going to be waiting a whole year. We're not going to wait a year. So then if you're not going to wait a year, why not start the process even before you do the cross-linking? Because not much is going to change after you get cross-linked. And it is going to change, but it's not going to be that much different than if you wait till a month after and then, 11 months later. So my feeling is kind of like, if we've got an opportunity to get them cross-linked like ASAP, that's fine. If their vision's not that bad, like one of the guys we did this morning, we saw a 17-year-old who we did crossing on his worst eye, but he's 20/20 minus and 20/40 with glasses, and he's happy that way. He's functional. Yeah, I'm not going to fit him in contacts now. But if somebody is really not functional with their vision and they really want contacts now, and but I think they need cross-linking, I will start fitting them even before we do the cross-linking. And that way, again, maybe you get the fitting part done, you get them trained on insertion removal, and then a couple weeks or a month after their procedure, they can start back up wearing their lens again. It's fine. But at least then you've got them already fitted and whatnot. So I think, again, I think there's a lot of ways to think about it. I do agree that after the procedure, it's probably wise to wait 3 or 4 weeks to resume lens wear. But I'm with you. It's like, well, do you really want to train somebody for INR at a month after their procedure when their epithelium is still pretty fresh? Kind of like them to know how to do it before they have the cross-linking done, if you can, so that when they get it done and they can resume lens wear, they know how to do it already.
Yeah. So fortunately and unfortunately, insurance sometimes dictates this discussion.
Sure.
Because sometimes we have to write a prior authorization and then get them on the schedule for cross-linking. It may be a couple months before all of those boxes are checked, and or you get the data that proves they're progressive. And so in that scenario, I would definitely start fitting them in a lens before the procedure. I think it also depends on like what's the patient's main goal and their visual acuity. Mm-hmm. If the patient walks in and they're best corrected at 20/80 in both eyes, like the patient probably wants better vision before they stabilize them. Because if we go through the crosslinking procedure and we're separating the two eyes by about a month and they need another month to wait, like they're 2 to 3 months out before they can even get a lens. And so in that scenario, I'd probably fit them in a lens first while I'm starting the paperwork on the insurance side. But if they come in and they're 20/20 and it's like early keratoconus and we can tell it's progressive in a young individual, maybe that's an indication that you drag your feet on a lens if they're already happy in their glasses. So It's somewhat patient dependent, but also like what's the fastest endpoint to getting both of these things done.
Yeah.
How functional are they with their vision? Can they function this way for a few months, or are they really not? Yeah.
Somewhat times the other indication is financially motivated too, is around this time of year, we have to take this into consideration from a deductible standpoint. Like you want to do both eyes within the same calendar year. Mm-hmm. You don't want to do one in December and one in February because now they're paying 2 deductibles unnecessarily. So around this time of the year, we're either trying to do jam 2 eyes in or wait until early January to do the first eye.
Yeah. When you have patients, and maybe Zac, you might be in the best position to answer this because, we, in that practice, there's a lot of patients wearing sclerals and then that weren't cross-linked because of, where cross-linking was. And now they're probably getting cross-linked. And maybe Jason, you can answer this too. How many times are you reevaluating their lenses and making a change? Like to your point, Jason, if they're wearing a lens pre-cross-linking, how often do you actually have to make a change after cross-linking, say 3-4 months post cross-linking, and they're wearing their sclerals from pre-cross-linking?
Very infrequently.
Okay. So minimal power change. I would agree that it's kind of another way to say like, hey, like just get these patients done in whatever order gets them to the finish line.
I think whatever change occurs is so slight and gradual that by the time it's enough to bother them, you're ready for a new fitting anyway.
Yeah.
Could be a year later by the time you're like, oh, I'm getting more fogging lately. And yep, something's changed, but we're due for a new fit anyway. So that's fine.
From a cross-linking management standpoint, I would agree with your mention, Zac, of that it's a relatively straightforward, typically non-complicated procedure in the post-op period, and that, ODs shouldn't necessarily be worried about co-managing this. This is something where we can do adequately and well, actually, because we have more time to counsel through the discomfort and make sure patients are feeling good about it. In your experience, Zac, you're probably doing both, right? You have some patients who stick with you and others that are co-managing. Would you say that on both sides in your office and in the externals that docs are doing well and patients are getting what they need? Or have you experienced any atypical healing processes, in one way or another?
I think in the past couple of years, I think we went over 100 procedures lately. So maybe out of like 120 procedures, we've had 2 patients that didn't fully epithelialize within like the 1 week mark. One was a type 1 diabetic patient, and the other one had really advanced keratoconus, really steep cornea. And so with a bandaged lens that was just a standard soft contact lens, I think it was rubbing on the apex of their cornea. And so the epithelium didn't have the ability to like crawl all the way up to the apex.
Yep.
And so took the lens off at like a week or took it off at a week, and then pressure patched, and that fixed it. Actually, I think it's the only time I've ever pressure patched. I don't know if it was done perfectly, but that allowed the epithelium to fully epithelialize.
Cool. Anything else you want to add to either of you to the keratoconus conversation?
I kind of have a question for you. How are you defining progression in maybe someone who's do you have a different threshold for what you're defining as progressive keratoconus in someone who's maybe 18 years old versus someone who's maybe 35 or 40 years old?
It's probably, maybe if I had to get picky, maybe change over time. Somebody who's 40 years old, it may take them, a year and a half to change a diopter again. And every patient is so different. Sometimes, we've had 60-year-olds that continue to change. And so we cross-link them at 60. It's not common. They're definitely not our most common patients, but, we had one patient who, cross-linked one eye and for whatever reason didn't do the other, and saw her 5 years later. And now she's 65 and she had progression by like 7 diopters on that eye. That's rare, probably an eye rubber or something like that. But it's hard because insurance is kind of a black and white definition for many of them on that, 1 diopter change or, half diopter spherical equivalent change in their refraction. And it's hard because that doesn't really take in age into consideration. A lot of the times in the letters we write, we'll say that, hey, this patient is young and keratoconus gets worse. Like, this is not an experiment. Like, this patient will get worse if we don't cross-link if they're 20 years old. Where again, if somebody's 40, we, maybe say, hey, like, we can, especially if their vision is at I don't know. It depends on patient feedback, I guess, on how aggressive I get. It's hard because, again, like, insurance doesn't really give us the leeway on what's considered progressive.
Yeah, you're trying to be too nice right now, Brooke. The reality is that we all have patients that we don't think are going to progress. And we all have patients that we think might progress. And we all have patients that we know are going to progress. And so in terms of following them, sometimes I'll follow someone like every 6 months with maps because I sincerely don't know if they're going to progress and I'm looking for progression. But if I have someone who's like 17 years old and they're already at a moderate state, I'm sorry, but the insurance company should not be dictating whether this is someone that should be done or not. So I'm going to try my very best to look for any indication that there's progression. And sometimes that indication might be pretty subtle, but I might push it because I think it's the right thing to do. And it would be wrong to deny the patient the procedure just because their insurance says it has to get worse first.
Yeah,
so,
I completely.
Yeah. So I think again, for example, the most high risk candidate or patient with KC for progression is a young female who's going to have children, right? There's been studies that show 100% progression during childbirth, during pregnancy and childbirth. There's no reason why that person should wait. Okay. So if I have to read their pentacam a few times to get the results that I think back up what I already believe, I'll keep taking them until I see results that I think can justify doing it. But it's not something where I think, I guess I try to look at the patient like you were saying and decide this person needs it. And I will make the numbers work for the insurance company no matter what I have to do because they need it. It's the right thing to do. Other patients, I don't know if they'll ever progress. Maybe they're 40 years old and maybe they're done. And I'm just really watching them and not in a hurry to do it till I see obvious progression.
Yeah, I think my threshold to crosslink a younger individual that we know is going to progress is significantly lower. And I think it's important for the audience to know when comparing topography measurements, it doesn't have to be from the same topography instrument. I mean, it's just a max K measurement. And so if you have a scan from a referring provider and your own, and they differ by a diopter and they're a young person, kind of like Jason mentioned, it may be an inner instrument error, but if you know they're progressing, you're doing the right thing for the patient by getting them on board and not waiting for their vision to get worse and deteriorate before you pull that trigger.
Yeah, there are definitely patients out there who don't necessarily need cross-linking right now. And so no one's sitting here saying, you should, falsify stuff to make it play your way. There are times when it absolutely can wait and you can watch. And I have patients I've watched who are a little older for 3 or 4 years and they're not changing. And we're watching them and I'm not going to push that person in and get them to do cross-linking when they haven't changed. But again, that 16 to 24-year-old who's already at a moderate stage, man, there's no chance that that person is not progressing. And in that case, like you said, Zac, you keep taking tests again at different dates and you wait a month or two or whatever you do, and you just look for the first sign that you can demonstrate change and you do it.
Yep, I agree. Well, that was a good discussion on cross-linking itself. And before we wrap up today, just want to go over a couple questions with you, Zac, on just, cool things. We want to know share a little bit more about you with our listeners today. So Cornea and Contact Lens Institute of Minnesota, founded by Jason in 2009, I think, right?
2010.
Okay, 2010.
Yep.
And then, do you still have patients that ask about him?
All the time.
That's so cool.
All the time, yes.
Yeah.
But that just goes back to what you were saying is that loyalty. And if you sold the practice today, Zac, and talked to whoever bought it 10 years from now, they'd say the same thing.
Yeah. I think that, and I agree. When I was there, patients, asked about you too. And again, those patients just hold on so tight, and I just love that. What's the coolest thing you got going on right now? Instrument, new employee, anything?
A couple months ago, hired Dr. Helene Pippin. So she's residency trained on cornea contact lenses out of Michigan. And so she's joined the practice. And when I joined the practice with you, I wasn't super busy, kind of sitting around waiting for the practice to grow. And I'm sure we waited too long to hire someone because she's her schedule's all the way full already. So I'm trying to figure out what, is this an aberration for 2 or 3 months where you don't have any openings, or do we expand your clinical hours? Because she's here 3 days a week now. So she's seeing patients right now, which gives me the freedom to do these type of things and advance certain things within the practice. But then beta testing a couple scleral lenses and ortho K lenses. And so getting into high-order aberration, correcting scleral lenses. And we do cross-linking once a month. And so yesterday was our cross-linking day. And so today was our one day post-ops.
Do you do any hand modification tools? That's what we're talking about next time.
No, but I would love,
You froze up.
I would love some, can you hand modify fenestrations? I would love some information on that. I don't know if it was that, or I don't know very much about fenestration.
Well, you'll have to watch the next episode.
Yeah. Thank you for that lead in. So we will definitely be talking about that in the next 1 or 2 shows for sure.
And Jason, that could be a good call to action if anybody's doing their own fenestrations.
Yeah, for sure. So, again, we do this call to action, and we do get some people who respond. And maybe if Zac and Helene can share this podcast with their friends too, we'll get more word out. But send us your cases. So again, you can send us anything. You can send us what overfilled you. You could send us a cool case. But specifically, if you have an interesting thing you've done where you hand modified lenses for a patient, we'd love to talk about that. And we will talk about that. Like, if you're like, well, how do you do that? I have no clue. I've heard about people talking about, but I don't know where to begin. You know, in a future episode, we'll talk about the tools you need to get if you want to do this and how to do it and all that good stuff. But if you're already doing it, shout out to those who are doing it. Send us your cases and we'll play them on air, and that will be a great way to further educate our watchers and listeners as to how that sort of stuff can be done.
Cool. I think that's it for today. Thanks for joining us, Zac, and have a great admin day catching up on stuff, and say hello to Helene for us. Good to see
you. Hopefully this inspires people to be interested in doing crosslinking in their practice. And that's something which, again, if you don't know Zac and you want to reach out to him and say, hey, I heard this and I'm really interested, contact us again through our media, Overfilled the podcast, and we can certainly pass it on to Zac if you want to talk with him more about how to do this sort of stuff yourself.
And I'll tag the clinic on our Instagram post for this episode.
Cool. Yeah, I'd love to help any listeners implement a procedure into your practice. It's exciting, and yeah, like I said, practice differentiator, and I loved stepping in for Dr. Kuzner. So
well, we'll see. She'll have to fight for her spot.
Right. We may not let her back in.
Yeah. All right. Well, have a great day, everyone. Thanks again for joining us on Overfilled the podcast.
Talk to you next time.